Welcome, everybody, to the January 2016 edition of Community Paramedicine Insights Forum. Welcome you to a new year and wish you a happy Martin Luther King Day. Today we have a good show for you, I believe, and just want to welcome you on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership Innovation and Research. And special shout out to Mayo and the Mayo family for giving us Gary Wingrove as my partner in crime here and supporting the Community Paramedicine Insights Forum as it has over the past 4 years. We really appreciate the use of your technology and the talent that Gary brings with him and his participation. Today's show will be in two pieces. First, we're going to talk about a new effort on the part of the National Fire Protection Association to develop a guide for community health EMS for fire departments. And then we're going to switch over, and I'm going to talk a bit about another initiative called for the past year the New EMS Initiative, now being called the EMS Value Initiative, and tell you a little bit about what that's all about and where we hope that it's going to head. And I will just also tell you that we will have a February CPIF edition, and that will be on February the 15th at 3 p.m. So without further ado, I would like to introduce Mr. Ken Holland. Ken is with the National Fire Protection Association and is the staff expert on the project to develop a guide for community health EMS for fire departments. And with that, Ken, I will turn it over to you.
Kevin, thank you very much. So my name is Ken Holland. As Kevin said, I'm a staff liaison with the NFPA. My official title is a Senior Emergency Services Specialist, and one of the many projects I work on is I work with our EMS Technical Committee, and that EMS Technical Committee has a couple different documents. One is NFPA 450, and another one, which they're just starting to develop, is NFPA 451, and that's a guide for it's a guide for fire-based community healthcare providers. Now, I want to, as just a brief presentation, I want to talk to you about what is NFPA 451, a brief history of 451 and how did we get to where we're at, some current activities that are surrounding the document, and also the future work on the document between the committee as well as reaching out to other national stakeholders, and also how to get involved in the document and the development of this document or any other NFPA document, but in particular this document. So NFPA 451, as I said, it's a guide for fire-based community healthcare providers. The document scope that was approved by the NFPA Standards Council based on a new project request that was submitted some time ago. The scope of the document, it's a guide that will provide direction to fire departments for planning, preparing, and implementation of non-emergent community healthcare programs in an effort to meet the changing needs of the communities they serve. The NFPA has several different documents, a guide. We have standards, guides, recommended practices. A guide is just it's recommendations. It's really informational purposes, things that you could do to meet the needs of your community. In this case, providing community health care, mobile integrated health care, community paramedicine program, whichever the community decides to call it. But one thing here it's worth pointing out is that it's geared towards fire departments. And again, that comes out of a meeting that was had back in 2014. I mean, it came from a new project request that was submitted to the NFPA following the 2014 meeting. That meeting was in Las Vegas, where the committee invited a lot of national stakeholders to the meeting to hear from the community what should the NFPA do with this subject. And one thing that came out of it was you should maybe develop a document that was geared towards the fire service. So with that, the request did go out for public comment. It's part of our process. Basically the form is, should the NFPA do this project or not? We did get back a robust amount of feedback, both good and supportive and not supportive. Our NFPA Standards Council did vote to approve the new project request maybe about 8 months ago. And with that, it was assigned to the NFPA EMS Technical Committee, which is chaired by, as many of you know, Kenneth Nipper. As far as current activities with the document, the committee did meet last week, or may have been a week and a half ago now, to begin development on the draft document. We had several committee members in the room, as well as several committee members on the phone and other national stakeholders on the phone to provide input to, what direction the committee should go and what information should be contained in the draft document. Again, it was a 2-day meeting. The committee managed to develop a draft outline of some possible chapters that they can work on. Because there were so many chapters, and with the way we handle many of our committee work and development of documents, to break it out into task groups. And the committee decided to form several task groups based on each chapter. And there's task group chairs that have been assigned to those chapters. And one of the things with our task groups is that you don't have to be a committee member to serve on a task group. And many of the committee members, or those that are serving as chairs of the task groups, might be reaching out to many of you to pick your brain and get you involved in the development of these chapters, which will then be incorporated into the drafts of the document. Which leads me back to another point where the scope of the document is for fire-based, for the fire service, but the committee also recognizes that it's not just the fire service that is doing this now and is very successful in doing it. So there's no need to reinvent the wheel if the committee believes that if they can pool resources, information, and knowledge together, regardless of the delivery model, be it fire-based or non-fire-based, it only serves the end user that much better to have a more well-rounded amount of information and input put into the draft of the document. That being said, too, even though it is geared towards fire-based systems, it doesn't mean that only fire-based systems can use it. It can be used by anyone that chooses to use or adopt this document or any other of our documents. Okay, so some future work on the document. So once the task groups are formed and staffed, they're going to meet to develop text for the chapters, and that they won't meet physically. They'll be meeting virtually online or through webinars or whatnot. But that's how a lot of the work is done with these projects. Is the committee meets to talk about work and then set out a work plan, and a lot of the work is done offline. These task groups are going to be meeting over the next several months to get this work completed, and it's just developing draft text for each chapter that we'll bring back to the full committee in the fall. And as I already said, some of these task group chair folks might be reaching out to many of you to get involved in the development. As I said, you don't need to be a committee member to serve on a task group, or you might just offer a bit of information and that's that. But the entire EMS committee is going to meet again in the fall of this year to put the draft together, and once that information is firmed up as to a meeting location, date, and time, it will be posted on the document information page for this document to the NFPA. So how to get involved. So as I mentioned several times already, the task group involvement, which is a great way to provide little bits of information to the task group so they can include it as draft text. You can attend any of our, attend the EMS Technical Committee, as I said, that's going to be in the fall. All of our meetings are open to the public, be it by physical attendance or through calling in or joining through our webinar process. And also NFPA 451 document information pages. And that, I didn't want to put the hyperlink in here because I wasn't sure if it would come through, but it's www.nfpa.org/451. And that'll show any information or activity for the document as we move forward. Or you could also reach out to me and I'll get you involved. And that could be either through connecting you with, task group chairs or the committee itself. But one thing too is that this document, it's still in a draft form. There's a lot more process that has to go on before it becomes a final document. So it's really very early on in the development stages of this document, and anything that is done in the document is subject to change until it becomes issued or published by the NFPA Standards Council, which could be in about 2 years. So as technology goes, it appears that I've lost my internet connection. So the next slide was just my contact information. Again, my name is Ken Holland. It was my email address is kholland@nfpa.org. I had my cell phone number on there, which was 508-942-4287. If you have any questions, you can either email me or call me. I'm usually pretty good with getting back to phone calls or emails. I've been reconnected. And I guess now, are there any questions that I'd be able to answer for anyone in the audience?
The conference has been unmuted.
Okay, all the lines are now live, and can I move your slides ahead so that you get your address and your phone number? And I would encourage our listeners to, if you're interested, contact Ken and get involved in this process. Gary and Matt Zavatsky, who's on the line, and I were all participated in that 2-day meeting by phone. And there's plenty of opportunity for folks to get involved in task groups. Are there any questions in the audience? Ken, can you give the address one more time for the document?
Sure. It's www.nfpa.org/451. And would it help to type it in the chat box as well?
Sure, that'd be great. So you can take a look at the chat box, and he'll have that address in there. Again, are there any questions for Ken? Well, Ken, thank you very much for being with us. I greatly appreciate your explaining the process to us, and hopefully you'll get some committee participants out of this.
My pleasure, and thank you very much. I appreciate the invite.
All right. We will move along to...
Kevin, do you want to leave the lines open?
No, why don't you shut the lines down?
Okay.
Thanks.
The conference has been muted.
All right, we'll move into the second part of today's session and just describe a process that's been going on for about a year now. At January 2015's National Association of EMS Physicians annual meeting, we held a meeting of 5 associations that are listed on the first slide that you can see, which are associations that have typically, over the years, have managed to do some really innovative and productive work together. Just happens to be a group of folks that things click when we get together and try and move projects or initiatives. And out of that came a paper which currently is called Defining the Role of EMS in Our Nation's Healthcare Transformation, the New EMS Value Proposition, and created a concept called New EMS, which is actually going to be somewhat downplayed after we just got done with a second large meeting of those associations at this year's NAMSP meeting this past week. And are doing a bit of transforming of the paper. But I am getting ahead of myself here and would just explain a bit of the thought and process that led to where we are today. Originally, this started off as an effort to do some defining of terms around community paramedicine and mobile integrated healthcare, we came to a point where a number of folks believed that it would be beneficial to carefully or more carefully define the terms community paramedicine, mobile integrated healthcare, and other related terms, so that as we started to move these concepts or continue to move these concepts to state legislatures or Congress, to third-party payers, CMS, and others, that we would have a clearer definition internally to EMS about what these things meant, as well as externally to these other folks who wanted to communicate the value of, or what we figure was the value of those services, and in moving such things as making them legal in the states to provide and starting to get some form of finance to support the services. So we held a meeting which originally was called a nomenclature incubator meeting to thrash these terms around. And what came out of that meeting a year ago, January, was actually quite a bit more than that. And as was, I think, very nicely stated this past weekend at our meeting, what we ended up trying to do instead was incorporate community paramedicine and mobile integrated healthcare within the concept of EMS and try to put them in the context of EMS, but also put everything else that EMS does in the context of EMS. That's sort of a clumsy way of saying, traditionally, we've always defined EMS as kind of this thing on the crossroads of public health, public safety, medicine, and it's variously described that way, but not in a very clear way. It's just something that sort of floats on this crossroad concept, when in reality, EMS has a space, a professional space, and a service space that offers, that is a very real offering of value to humanity, to the public. And it's time, we realize, to claim that space, name the space, define the space, and then continue to sort of shout that from the mountaintops, that EMS is this space in the community and provides these services and these values to the public. So that's what the effort essentially became. A paper was drafted over a period of several months to kind of define that, and what we ended up doing was defining EMS in terms of the values that it offers society and the service lines that constitute what EMS is or should be in the future within the context of the new healthcare environment. In July of last year, the paper went out to the 5 associations. It was written by representatives of the 5 associations, but it went back to those associations for endorsement. To date, 4 of the 5 have endorsed. 1 is still considering. And there's some tweaks that are going to go into the current paper to aid that 1 association in then endorsing. We have also subsequently, just recently in December, sent the paper out to associations who are members of the Joint National EMS Leadership Forum to solicit their endorsement. With the meeting this past week, there are going to be some changes in the paper, and we're going to end up sending that back out to those associations for their consideration. The changes are not going to be monumental. There's some things there are some oversights made in terms of some things we should have included and didn't, but I don't think that they are going to be hugely substantive. They're not going to be substantively difficult, where somebody might have endorsed the paper the way it was and now wouldn't endorse it. I don't think that will happen at all. And again, Matt Zavatsky's on the line, and Gary Wingove is as well. And they were at the meeting in San Diego with me and representatives of the other associations. So I invite them to add their 2 cents worth when we get towards the end of this. So in process, we are going to move forward once we start getting endorsements from the associations that we're soliciting endorsements from. An endorsement will essentially mean that that association will join something we're calling the leadership group for the EMS Value Initiative, which is what it's going to now be called, rather than the new EMS Initiative. And that leadership group is going to look at defining EMS in a way, probably from a component approach. And those of you that may be familiar with the original 15 EMS components, things like medical direction and education, facilities, and a variety of other things that make up the EMS system, we're going to have a set of components, and different associations will take responsibility for different components and fleshing those out. And in the end, the idea is that we will have a set of tools that will enable a service to move from sort of the traditional emergency EMS providing service and become a new brand of service with a new set of values. And this product will provide tools for services to do that. Incorporating community paramedicine, getting involved in mobile integrated healthcare, or whatever is appropriate to whatever the service wants to become in terms of the new EMS definition. So let's take a look at what this is all about. We recognize that healthcare, the basic foundation of all of this discussion is that we are going to, in general in healthcare, transform from a fee-for-service delivery model to a patient-centered and value and outcomes-based model. And that EMS does have a space of professional service within communities where it is ideally positioned to provide a bunch of this service beyond emergency response and interfacility non-emergency transport to help the healthcare system achieve that goal within the triple aim definition of improving quality and satisfaction, health of populations, and reducing costs of healthcare. We believe that whatever we call this new state that an EMS service must attain, maybe new EMS or EMS 3.0, but it's basically a new value for EMS. And the way that we are going to express how that changes from what was to what will be is in terms of the service lines that EMS professional service or EMS professional space offers to the community, and the value of those service lines to the community. This actually is not a particularly new concept, as I'll explain in a minute. But just to give you an idea of service lines and values, EMS in the pre-1970 world was essentially the service line was transportation, patient transportation. And what was valued was fast response to a patient, fast transport to the hospital where actual care could be provided. After 1970 and the EMS Act of 1973, as EMS modernized, we added patient care, medical care to the transportation service. And so the value was not only fast response and transport, but medical care, life-saving care, done in a quality fashion. After the EMS Act of 1973, starting in the early 1970s and progressing for just about the next 10 years, as long the length of the federal EMS program which existed at the time, there was a general concept that EMS had a very broad reach, that EMS should be doing primary prevention services in order to prevent injuries and prevent emergency illnesses from happening in the first place. That only when we were unsuccessful in that primary prevention role did we do secondary prevention, which is essentially turning the lights and sirens on, going out and trying to mitigate whatever that emergency illness or injury was, the impact of that on the patient by providing care and getting the patient to definitive care. And then it extended to tertiary prevention, which is essentially rehabilitation, so that patients wouldn't end up coming back and being re-injured or have a further medical emergency, that they become sufficiently rehabilitated. Unfortunately, fortunately or unfortunately, I think it's unfortunate, that definition of EMS became very narrowed over the next 10, 20 years, to the point where EMS became simply emergency medical services, response to emergency medicine, to emergencies of a medical nature or injury nature. It became only the secondary turn on the lights and sirens service, and that was it. And today we see a lot of fallout from that. As an example, when community paramedicine and mobile integrated healthcare are trying to be implemented in states, many state attorney generals are saying, no, you can't do that. The state EMS authority has no authority to approve anything other than emergency medical services, and nothing out of emergency is allowed. So no CP, no MIH. And that's just becomes a barrier that we've had to overcome. As we saw a return to that concept, however, in the EMS Agenda for the Future in 1996, where the definition of EMS in the future would be a community-based health management service integrated with a healthcare system and providing prevention services for conditions that would become medical emergencies or injuries down the road, and became concerned again on the other end of trying to help people who have been injured or been through a medical emergency rehab, so that they wouldn't become a readmission to the hospital or a revisit to the emergency department, stuff that today we very commonly associate with community paramedicine, mobile integrated healthcare. The Rural and Frontier EMS Agenda for the Future in 2004 restated that, the importance of EMS as part of the community health system, and talked about a new service line, community paramedicine, as a way to accomplish that. So the new EMS value proposition is simply that we have to change our paradigm, that in order to remain relevant and valued within our communities and in the healthcare system, we have to offer service lines, including a broader array of emergency and preventive medical services that meet specific needs in their communities. Doesn't mean that we go out and try and duplicate what's already being provided, but as has sort of become the cornerstone of community paramedicine, we address gaps in the health care of any given community. And I think the last statement here is important, that it really is important that emergency medical services in all communities regardless of who provides them, how they're paid for, need to assess their goal in life, their mission, with regard to the services that they're providing the community. Because the way that healthcare is being paid for, and there's no reason to believe that EMS is not a part of that healthcare and its ability to generate revenue, it's going to change. And that down the road, though a service may entirely live off its tax-based support as a community service, even those services that don't charge for the care they provide, those things can change. And in all likelihood, as the healthcare system and how it's paid for changes, the way people look at EMS and how it should be paid for is likely to change as well. So, and I'm sorry that this is such a busy slide, but I just wanted to put all the pieces that to date we've identified as the service lines that need to be a part of the new EMS, EMS 3.0, whatever you want to call it, that sort of defines or adds to the EMS value of that space, the space that we need to claim as EMS's professional space. And these include emergency medical dispatch with advice lines for patient navigation, provided one way or another. Nothing changing with regard to the need to provide rapid response, emergency and critical care through ground and air medical transport, to provide interfacility and other medical transportation, to continue to provide basic and advanced life support, medical assessment and intervention, and all of the specialty types of services, critical care medicine that we provide, the tactical and wilderness emergency care that we provide in some areas. We also have to add into this set of service lines taking our ability as responders, emergency medical responders, and using the talent that we have in organizing those services and offering that logistical, operational, clinical support to systems of mobile integrated health care. This paper, and I'll talk a bit more about this in a minute, does discern between mobile integrated health care and community paramedicine. And so that's an important part. And EMS does have an important role in supporting mobile integrated health services that may be offered by an EMS agency, or they may be offered by an entirely different entity like a health system or a hospital. We add to the service line community paramedicine services, which are services provided by EMS. They may be an integral part of a mobile integrated health system, or they may be operating as a standalone set of services, and they include urgent medical assessment and care, preventive medical assessment and care, chronic disease assessment and management support, post-discharge follow-up assessment, and then based on the assessments that I've just described, patient transport, arranged transportation, or referral to other community health and social service resources. So that basically is the service line that we're talking about new EMS having in that professional space now known as EMS. And as a total aside, and we may get to the point where EMS simply it loses its acronym of emergency medical services, and it's just called EMS. And it involves all of those service lines, emergency and non-emergency. The value that we bring to the community in providing those service lines is especially attractive because EMS is virtually in every community. And we're fully mobile, and we're able to address patient needs 24 hours a day. And we're there. We're in people's homes all the time. We are an expected, respected, and welcome source of medical assessment and care, and we are welcomed into people's homes. We provide a highly reliable patient assessment and intervention service during 911 calls and in response to emergency, urgent, or unscheduled episodes of illness or injury, where people love us, basically, and respect us and our abilities. Through the service lines that I just described, we can navigate patients needing urgent or unscheduled care through the healthcare system. We can be, because we're in the community and we're known, we can be the entry point for a lot of folks in the community who trust us to get them aimed in the right place within the healthcare system and to be comfortable with that and to do the right thing. Because we have the healthcare safety net and are in the community 24 hours a day, we are able, by adding the CP and participation in MIH services, to fill gaps in patient care with other community, as defined by needs assessments and by other providers of healthcare within the community. And we can prevent new or recurrent medical episodes through these services. And I think this is, of this value is one that is waiting for us to simply realize. Mobile integrated healthcare is a model in which a variety of community healthcare providers organize to deliver a broad spectrum of patient care, and EMS can be a very fundamental role in the value that MIH realizes. So how does community paramedicine differ from mobile integrated healthcare? They're both intended to be patient-centered mobile services offered outside of hospitals and other facilities. Community paramedicine is an extension of EMS paramedicine practice and services to address healthcare gaps in communities. It is entirely EMS-based services, EMS providers in EMS vehicles as a part of an EMS service addressing those healthcare gaps in a non-emergency healthcare provision role. Mobile integrated healthcare, on the other hand, is it does that, but in a broader with a broader array of providers. It's a multidisciplinary service consisting of doctors and nurses, nurse practitioners, mid-level practitioners, and yes, perhaps community paramedics, EMTs, paramedics, dentists, dental assistants, a variety of different types of clinicians that are organized in through administrative arrangements, whether it's contracts or other agreements, to provide those services outside of facilities. It is not owned generally. It's not an entity of EMS, although an EMS agency certainly could be the lead entity for a mobile integrated health approach. One of the definitions that may or may not be helpful in understanding the differences between these is that the EMS and community paramedicine of the future operate as services that operate within the EMS system of the state. And the state licenses the service. It may certify community paramedics or give them some other blessing once they can have shown that they have the training required to do community paramedicine. But state EMS will continue to regulate and lead those efforts. So the entirely EMS agencies and personnel who provide the new lines of service that I described are going to continue to be licensed by state EMS offices. And community paramedicine is one of those service lines. New EMS agencies, those licensed EMS entities, may have contracts or other agreements to integrate their CP services with other health and medical entities, facilities, payers, and systems. And that would actually fall short of can fall short of actually being a mobile integrated healthcare service if there's not another broad array of providers outside of the EMS realm, the traditional EMS realm, providing those services. There are a variety of titles given to the practitioners of community paramedicine. I'm not going to read these. You can look at them for yourself. And generally, state EMS agencies are approaching community paramedicine and the folks that are providing it not by creating additional licenses or licensing levels for EMS personnel, but by recognizing or certifying them in an add-on to their existing licenses. In some states, and this is a concept that Gary has encouraged, that there may be other non-EMS healthcare providers who go through a community paramedic course and may come out the other side and be called community paramedics, so they may have a nursing background or a different background instead. Within community paramedicine, it is possible for other personnel to operate within a community paramedicine program without it necessarily becoming a mobile integrated healthcare program. Another example would be today's flight programs or helicopter programs or fixed wing EMS programs often utilize flight nurses or other professionals that are licensed by the state EMS office. And in the same vein, there's no reason that these folks could not operate within CP programs and be licensed by the state EMS office. Again, mobile integrated health care is an administrative arrangement. It's not something that, because it purposely utilizes a wide variety of practitioners or practitioners outside of the EMS as well as inside of the EMS. By virtue of that, the state EMS office is not going to regulate an MIH program. It does not. The professions that are involved in MIH programs are already regulated. They're already licensed, and the particular arrangement at this point, with the exception of one state that I'm aware of, is unlikely to be specifically licensed by the state EMS office. How do current EMS programs take the step to transform? Well, a lot of the EMS value initiative is going to be to define that, as I said at the outset, and to provide tools for EMS services to make that jump from the EMS, the emergency response EMS, or the non-emergency transport EMS services today, to the full service line occupying the full EMS service space that I talked about at the outset. But there's some things that people can start to do. Make sure that there are folks within the EMS organization who understand and embrace the new EMS value, that it needs to be a multi-service line approach, and that you have practitioners who are good at, willing to provide community paramedicine, as an example. It's certainly not for all EMS folks. The trauma junkies that we all tended to start out as when we got into EMS are not necessarily the best CP providers. And yet there is certainly, we've seen that EMS providers can become good community paramedics. We need to strengthen competencies in all of the professional levels within the EMS agency so we can occupy that whole EMS professional space, because we need to be able to, once we identify unaddressed community health care needs, we need to be able to be adaptable to providing those. We have to embrace continuous quality improvement and find ways of embracing and establishing arrangements in pay-for-performance and value-based purchasing reimbursement that's linked to clinical outcomes. That is the way that EMS is going to get paid for in the future, and we need to start getting ourselves prepared for that. We need to be innovative. We need to be looking in our communities to see what opportunities there are for EMS to address healthcare gaps. We need to then clearly tell how other healthcare providers externally, as well as our own providers internally to EMS, what is our space professionally, and what is it that we do within the community. We need to define that professional service, that professional space, and we need to claim it and make sure that folks understand what it is that we can do. One of the problems in moving to community paramedicine is that other providers don't know what paramedicine is in the first place, what we can and can't do clinically, operationally. We need to move towards college-based education for EMS. And again, as I said, we need to assess the potential for CP programs to address the gaps in the community, whether it's through a community paramedicine program or participation in a mobile integrated healthcare system set of services. Once we undertake a CP or MIH program, we need to make sure that we have the tools to measure its performance and that and measure the degree to which we are achieving the triple aim in terms of lowering costs, maintaining a quality service that meets the patient's needs and with patient satisfaction. And if we can, that measures what kind of impact we're having on the population's health. Sorry, I'm having trouble.
Is that your last slide, Kevin?
Okay, yes, you're right. That is the last slide. So, you know, in that is the initiative now called the EMS Value Initiative, and it, I think, clearly shows a difference in expectations, a difference in value, and you know, through adopting a new set of service lines. And I'm really looking forward to the work over the next year with the association to embrace the concept, to fully flesh out the tools that we can offer services to make that transformation. Gary, I'm glad to take questions.
All right.
And I certainly would like to, and I would like to invite Gary and Matt Zabadsky to comment as well.
The conference has been unmuted.
Kevin, this is Matt. You did a great job with a very complex topic. The one thing I wanted to reinforce for everybody on the call is that one of the main reasons for undertaking this Herculean initiative was to help develop some industry alignment around what EMS of the future if you want to use that term since it's been used in the past, but what EMS 3.0 really needs to look like, what, as Kevin indicated, was Space 2EM, but more importantly, try and get all of the associations to embrace the future and to work together towards a common vision, and to realize that vision. And once we have that industry alignment so that everybody sort of understands where we believe we can bring the most value to the communities, to the payers, to the healthcare system stakeholders, then identify, in order to realize that vision, what specific association should own that space to move us into that area. So Kevin mentioned reimbursement reform on a global level, not just CPMIH, but total reimbursement reform. What association is best equipped to lead that effort, and that we all, as the other associations, support their efforts? So that might be the American Ambulance Association. When it comes to educational standards, to make our profession truly a profession, it may require a total redo of the educational programs and how EMTs, paramedics, community paramedics, others are educated. Well, the National Association of EMS Educators is most logical for that, so they develop that vision, they lead it, we support it. Same thing with regulatory and statutes, so NFPA, so that really all of us, and certainly from the medical direction side in the EMSP and getting behind them to support that, so that we're all working together, pushing the boulder in the same direction to actually have this vision come to reality in the new healthcare system. That's all I had to add, Kevin. Great job.
Thank you, Matt. That was very useful. I appreciate that. Gary, do you have any thoughts?
No, I think you both did a great job.
Okay, do we have any questions or observations? Wow, must be a holiday. Okay, well, very good. I hope this has been helpful to all, and we will call it an end of the January show, and just remind you that we will be on February the 15th at 3 p.m. Eastern Time. We are going to have, I believe, a show from Maine, and show a service that community paramedicine service that has been is being offered from inside a home health agency. So we look forward to having that and seeing you again next month. Thank you all, and have a great day.